David Wallace, founder of PV Reporter and our nonprofit sister organization, MPN Cancer Connection. I'm an MPN patient advocate living with polycythemia vera since 2009 and your host for today's Patients Are Asking program. We would like to thank our sponsors, Pharmacentia, AbbVie, and Insight for their support of today's program. Today, we are excited to have Dr. Michael Grunwald, Chief of the Leukemia Division at Levine Cancer Institute in Charlotte, North Carolina. And Dr. Grunwald is also my MPN specialist. Thank you for joining us today.
Thank you for having me. It's a pleasure to be here, Mr. Wallace.
So in the last several months, two medications have been approved by the FDA for MPNs. Bezremi for treating polycythemia vera and Vonjo for myelofibrosis. What drugs in late-stage clinical trials are you most excited about?
So first of all, let me say it's super exciting that we have two new agents for MPN patients. Ropeg interferon or Bezremi for polycythemia vera at present, and pacritinib or Vonjo for myelofibrosis. Both of these are addressing an unmet need, I think, in the care of MPN patients. And they also show that there's more excitement and more resources being devoted to developing drugs for MPN patients to make their lives longer and to make their lives better. Because we know that a lot of patients suffer not only from the possibility of life-threatening problems, but also from day-to-day symptom burdens, sometimes splenomegaly that can make life hard, and difficulties with managing their blood counts. So I think these are great advances, and I look forward to more advances in the future. Now we've got a lot of investigational therapies. There are so many of them in myelofibrosis, and I won't name them all, but I've seen encouraging data regarding navitoclax, which works along the apoptotic pathway, so tries to get cells to apoptose or die. And we want our cancer cells or MPN cells to undergo programmed cell death. So navitoclax has these encouraging data to support its further development. Pelabresib is also exciting in myelofibrosis. I've seen some encouraging data in the group of patients who are not having optimal responses to ruxolitinib or had lost their response. Imetelstat, the telomerase inhibitor in myelofibrosis, is very exciting. And then momelotinib, which is a JAK2 inhibitor, so it's this familiar pathway like ruxolitinib and fedratinib and pacritinib. So we have three JAK inhibitors approved. Momelotinib is also a JAK2 inhibitor, but it does not seem to cause as much anemia as some of the other JAK inhibitors. And this is encouraging because anemia can be a pretty big problem in myelofibrosis. So I think we've got a lot of exciting agents in development for myelofibrosis, and hopefully we'll see more approvals in the future. And then I'm also very excited about rusfertide, which is a hepcidin mimetic in polycythemia vera. I think that this drug has exciting early stage data and is moving on in clinical trials. So we might have more for multiple MPNs in the future. And I think this is good for patients. Just more options is always better. Not all patients need to take advantage of all options all the time. But the fact that investigators are excited, companies are excited, and patients are energetic in supporting the development of these drugs is really a good thing.
So as a patient advocate who communicates regularly with our community, the most important tip that I tend to share with the newly diagnosed is learn about your illness, become your own advocate, and see an MPN specialist. So it's not uncommon for a patient to say, well, the nearest specialist is hours away from me, or how do I even go about getting an appointment? So tell us how someone who sees a community oncologist or hematologist can get an appointment with an MPN specialist like yourself, and what are the benefits in doing so?
Yeah, that's a great question. So a lot of my patients come from far away in other places within the Carolinas and neighboring states, sometimes even farther away. And for these patients, they can't come back and forth to where I work in Charlotte frequently. They have to stay where they are, get their blood drawn there, and see their doctor in that region where they live. But when I meet the patient, I'm able to collaborate with the patient's regional physician and come up with a treatment plan and monitoring plan, and then check in periodically with the patient and or that provider to see how things are going, and also to make adjustments to the plan. And that is not uncommon at all for me. And so for patients who are seeing a community oncologist and who desire to see either an academic physician or a specialized physician in myeloproliferative neoplasms, I think having a conversation with that provider is important. And some providers would be very happy to refer the patient and then collaborate in the patient's care. Not everyone is going to be happy to do that, but most providers are willing and able and happy to do that. And I've had generally good experiences where I'll see the patient, I will communicate periodically through a messaging system that's secure or by phone with the provider who's also taking care of the patient. And I share my ideas. And I also am a listener, because sometimes the patient's other hematologist, oncologist is picking up on things that I'm not picking up on, or might have more up-to-date information than I do about how the patient is doing. And I might have good ideas too about treatment and or monitoring. So I think having an open line of communication both ways is very important. And I think that the patient's having an open conversation about a referral to an MPN specialist, so that they're not doing it blindly, not seeking an MPN specialist blindly, is important. Now, for patients whose provider does not want to refer them to an MPN specialist, but the patient still desires to see an MPN specialist, they can call directly for an appointment with physicians at most facilities that I know of. It can be in those cases where there's some reluctance to make the referral. Sometimes the communication is a little bit different in those cases than in the majority of cases where regional providers are happy to work with MPN specialists.
Okay. And so one question that kind of comes to mind for me is, will you or a member of your team be asking the local hematologist for, X amount of past CBCs or, any test results, so you'll have a chance to review ahead of seeing the patient?
Yes. So it's very helpful to have as much information as possible. It's helpful for me to see any previous blood counts, any prior workup that's been done, including mutational status, chromosomal abnormalities that a patient might have, a bone marrow, not only the report of the bone marrow, but bone marrow slides. If a patient's had imaging, for example, imaging of the spleen, that's very helpful to have as well. And so I like to have all that information when I see the patient. And if not, we work with what we have, but we certainly like to have as much information as possible. And we like to share the information that we generate when we see the patient. And if a patient is periodically seen at two different places, let's say they're seeing me at our center, or one of my colleagues at our center once a year, and maybe they're seeing a physician in the region where they live once a month or once every 3 months, to share the information and the blood counts and so forth that are generated at those visits both ways is pretty important, I think.